So the next part of looking at our medical education curriculum is the clinical years. And so really we have both in the clinical curriculum committee and we have a steering committee that's looking and taking a deep dive into our clinical curriculum, really trying to figure out how can we have the most innovative, cutting-edge clinical curriculum that will allow you guys to leave here and be the best possible physicians ever. And as you know, there are many components to that. And so one of the things that we're looking at is how do we teach? How do we teach you in the third and fourth year? So I'm going to ask you to indulge me for just a couple of minutes, because you're going to look at the next couple of slides and you're going to say, you know what, Dr. Mann, you've clearly lost your mind. You forgot why you came here to talk to us. But I just want you guys to indulge me for a second. So let's begin. All right, a penny. Everybody's seen a penny, right? And I'm sure gazillions of times. Fair? All right. Which one of these represents the front of a penny? And don't take your change out. You can't take your spare change out. How many of you can confidently state what the front side of a penny looks like? Yes?
J. E.
J. Okay. Everybody agree with J?
I'm thinking E.
E. Okay. Anybody else? Don't look. Don't. What's that? Okay. All right. So it sounds like there are a lot of different opinions. That's really interesting. Have we not all seen this millions of times? Okay. So you know what the correct answer is? It's A. Does that not blow your mind? I mean, does that not blow your mind? This is something that, right, this has nothing to do with learning about medicine, or does it? The point of this is that we have seen this millions of times, and I'll be honest with you, I didn't know the answer either. And what this is showing us is that just having something appear in front of your eyes many times, in other words, that repetition is not enough, right? It's not enough to really get something ingrained into your brain and to remember it. And so we're actually looking at here is a really basic principle of how we all learn. So it's not just repetition, right? It's not just staring at something on the page and hoping that it'll kind of stick in your brain forever. Can you all think of something that you might do that is similar, or maybe that you have done that's similar to having a penny appear before your eyes over the last 20 to 25 years, that you might do in some of your study techniques that may not work? How many of you use a highlighter? Or did before you came here? Oh God, I did. I can remember when I was, many years ago, I was using blue and orange and yellow and green, and the pages look beautiful, but you know what? It doesn't work. So one of the things that we have realized as we've tried to figure out how do we not only get material, but how do we keep that material in our brain and then learn how to apply it, is that we've got to do more than just show it to you. Because clearly, if all you had to do was just look at something once or twice or a million times, it would stay in your brain. And clearly that doesn't happen. So that's one of the basic principles that we're thinking about. So how do we put our clinical curriculum together in a way that's really going to foster long-term retention and understanding of the material that you're learning? Okay. Let's see. So let's just take a step back, stop chewing your pizza for a second and just imagine, all right? What if you could remember everything that you learned in your systems courses, right? So everything that you have learned and everything that you're going to learn when you start your third year. What if you had this amazing repository of knowledge in your brain and you were able to bring it up, right, whenever a new situation arose that maybe you hadn't seen, or better yet, something that you learned about, you can say, oh yeah, I remember seeing that. And what if it's possible to not forget every single thing that you've learned and to add new knowledge? That'd be kind of cool, right? So this is possible. All right, so I'm going to have you indulge me for just another minute here. So what if I told you, get this off the screen here. What if I told you that sometimes when it's hard to learn things, that it actually, when you feel like it's taking forever to learn something, or that you really, you're just spending so much time, that you're more likely to remember that material. Not just have it stored in your brain, but you're more likely to understand how to apply it when the situation arises. Okay, so that's one thing. And what if we said and we know that repetitive practice, right? So just reading something over and over again, or just highlighting it, or just seeing it on a page is not enough. But that your brain, right? Your brain is kind of like a muscle. Because for those of you who do any kind of activity, whether it's physical activity, right? Whether you play an instrument, maybe you're a runner, maybe you play a sport, you get better at it, not by doing the same thing, but by trying different approaches to improve your skill. Well, clinical medicine is no different than that. And that one of the ways that you can remember information is by, just when you think you've forgotten it, go back and try to remember it. And I'm guessing that you're probably doing that in your courses right now. So for example, you guys, you're learning about cardiovascular, the cardiology, renal, pulmonary. You must have gone back to some of your earlier courses and we're trying to remember, okay, what was that cell process? Now I just can't remember. And then you remember it, right? You go back and read about it. It's like, oh yeah. And then it's going to stick in your brain. Okay, so by actually learn something, almost forget about it, and then go back to it, it helps things stay in your brain longer and helps you be able to use that information and apply it down the line. Okay, these are tried and true practices. We know this is how people learn. And you guys probably know it too, because we all know you can use your favorite color highlighter and just keep highlighting the page. It's not going to get that information to stay in your brain for the long term. It may work for the short term, right? It may get you through an exam, but it's not going to help you when you've got that patient who comes in with that complicated problem and you got to go back and think about the anatomy or the physiology or the biochemistry or the genetics. Okay, so why does any of this really matter? Did I just want to take an opportunity to tell you all about some of the interesting ways you can learn? No, it's a lot more than that. Because, and to give you free pizza, because I don't want anybody not to have lunch. No, it's more than that. Because what we're talking about is how are the things that we're taking into consideration as we rethink our third and fourth year. Because we're trying to think about how can we set up our clinical education in a way that's going to optimize how you learn material, so that you can take what you've learned in foundational sciences and apply it, really bring some clinical meaning to it, and it's going to help you remember some of the things that you've learned and apply it to new situations. Because what you're going to be doing, what you're doing now, what you're going to be doing in your third year, your fourth year, and beyond as residents, attendings, this is something you do every day, okay? So we want to set you up for that now. So the reason that this matters is that by the end of the third year, as we're thinking about how we're constructing and redesigning the third year curriculum, this is what we want to make sure that we have helped you accomplish. We want to make sure that you will have all the knowledge and skills so that you can figure out any clinical challenge that comes your way, regardless of the discipline, regardless of the specialty. Now, is that to say that you're always going to have that information at your fingertips and that you're always going to get it right? No. But we're setting things up so that you'll have the skills to know where to look. Or you'll say, oh yeah, I remember where the ureter went, but I just can't remember exactly where it is in relation to the uterus. That's okay, you can look that up, but that you'll know, you'll be thinking about it. Okay, so that's the first thing. We want to prepare you for Step 2 CK. Let's talk about the elephant in the room. We know that exam is looming. But part of preparing for Step 2 CK is that you've got to think about how things connect. Step 2 is not it's not rote memorization. And it's more about really thinking about how things connect, thinking about systems connections. And when you look at all the content that's in CK, about 20 to 25% of it is really about how different conditions are managed by looking through different lenses. Right? So you've got a patient with abdominal pain. All right, well, is she pregnant or not pregnant? Or is this a GYN issue? Or is this more of a medicine issue, right? So we want to make sure that we set you up to think that way so that you'll be ready, that we're very intentional about facilitating those connections from the foundational science years into the clinical years. Because one of the things that we've realized as we've been rethinking our clinical curriculum is that we talk about how important the foundational sciences are, but yet we need to be a little more intentional and deliberate about having you think about that material and how it applies to the clinical care of the patients that you see. All right? So for example, you're taking care of a patient who's had an MI. Okay, so what's really going on? What is it? What is the structure of those coronary arteries? What happens when they get obstructed? What does that look like? Right? What does a thrombus look like? Because if you understand that, you're going to understand why we use the different medications that we use or the surgical approach that we use. So that's how we're going to bring foundational sciences back in. It's not just remembering, oh yeah, here's what a thrombus looks like, and but it's how does it connect with the clinical context in which you're practicing? Because that's how you're going to remember information. That's how all the material that you're learning is going to stay in your brain, and it's going to be at your fingertips when you need it. And then we're setting up the third year so that we want to make sure that you can actually connect content across disciplines. Because the way we have our third year set up right now, the specialties are great. We have some really strong clinical departments. But what we're not doing, and what we're taking an opportunity to do, is to really think about, okay, so if I have a patient who comes in with a headache, how would that patient be managed in a family practitioner, and if patient we're seeing a family practitioner, versus in a neurologist's office? What's different? What are some different considerations? What are some different ways to look at things? Okay, so we're setting up our curriculum to do that. And then probably the most important thing, and I will tell you that we have received so much feedback about this from your classmates, third, fourth year, and students who have graduated, about how we assess your clinical performance. So one of the areas of focus as we undertake our clinical curriculum reform is how can we do a better job of assessing your clinical performance in a way that's fair, objective, and accurate. And so that is going to be one of the endpoints of this whole reform process. And you'll hear from your classmates in the third and fourth year that the clinical competency evaluations just aren't fair. It's a system, and we game it, and there's some truth to that. So we have listened to that feedback, and we are now rethinking how the clinical performance assessment is designed, and we're making it better so that it truly, truly reflects what you are learning and what your clinical skills are like in the third year. All right. How does that sound so far? Is it exciting? Is it interesting? Yeah, I think so too. Okay. So what's our plan, right? This all sounds great, but do we have a plan? So that's what we have been, our clinical curriculum reform steering committee has been meeting since July. And actually, we've been talking about our clinical curriculum in the clinical curriculum committee since the middle of 2019, kind of thinking about how we make changes. And you guys know, change takes time. We can't just snap our fingers and one day say we're going to change everything. We really have been very thoughtful in how we're planning. We've looked at feedback that we've received from folks who've come before you. We've looked at our GQ. We've looked at feedback from program directors. We've looked at a lot of different metrics. So what we know is that we want to support how you learn the information. Like, as we just spent some time saying, you can't just stare at it. So we're focusing on how you integrate your knowledge. And so what that means is that we want to make sure that we really have a clinical curriculum that parallels the paradigm that's been used in the first 2 years about synthesizing and applying your knowledge across different systems. We want to make sure that we set up a structure where you can connect your foundational science knowledge, your clinical science knowledge, and your knowledge of health system science across all clinical education. So health system science are those other core disciplines that are incredibly important. Population health, healthcare equity, ethics, value-based care, healthcare financing. So that's some material that is certainly, we deal with this on a daily basis, but we want to be more intentional about how we actually ensure that we teach that to you in the third and fourth year. And I know that you have had some of these discussions in your first 2 years. You've talked about the business of medicine and things like that. You've talked about ethics. But we want to make sure that we continue all those threads. So this is not just about understanding anatomy and physiology and biochemistry. It's also about all the other components of the care that we give and how we practice as physicians and the things that we need to know in order to provide the best possible care for our patients. So how we approach your education is changing, and how we assess what you've learned is changing. So that we are really, we've taken a very deep dive into our clinical competency evaluation, redesigning it in a way that we think is going to be a lot more fair and is going to give a more accurate picture of what you have done during your clerkships. And being more really objective and fair. That's really our goal. All right. So what will your third year look like? So one of the reasons that I wanted to touch base with all of you today is that I wanted, as the months go on, we'll be having more discussions, but to let you know what is going to be present and how things are going to change. So what is not going to change are the disciplines that you will learn about. So it's still going to be family medicine, internal medicine, neurology, OBGYN, peds, psych, surgery, and then a 4-week elective. So that hasn't changed. What's different is the amount of time that you're going to spend in some of those disciplines. And then if you notice, make sure I've got my, which one of these is for the laser? Is it the middle one? Oh, I know what. I forget I can do it up here. Here we go. There we go. So what we've added is something called an integration intercession, and you can see 2 of these. And so these are 2 3-day pauses, if you will, that, well, there'll be different activities that are going to be very intentionally connected to some of the things that we were talking about. So we said integration is important. So one of the activities is going to be the assessment of how you actually think about patients across disciplines. We're going to extend our equity, our health equity curriculum during this period. We're going to extend ethics. So we're going to use these 2 intercessions as opportunities to make sure that we include content that you started to learn about in the first 2 years, but we also want to include content that is going to help you bring everything together, that's really going to help you think about how you manage patients looking through different lenses. So that's one thing. The other thing is that there's a reason why the different disciplines are located next to each other. So as opposed to kind of the traditional format that we've had where you can take these in any order, family medicine and psychiatry will always be taken together back to back, whether you do psych first, then family medicine, or family medicine, then psych. Same with OB peds, same thing with internal medicine and neurology, and surgery and the elective will always be paired together. And the idea is that as we are structuring how we deliver the third year content, we are being very intentional about thinking of common conditions across these dyads that are linked together. So again, try to help you start thinking and really encourage you to think about how do different specialties manage the same condition? What are some things that you need to think about? The other piece of this that's really important is, as we mentioned, we're bringing foundation. We want to make sure that we very explicitly integrate foundational sciences into the 3rd and to the 4th year. And so that a big part of this will be thinking about pathophysiology. There'll be a lot of focus on pathophysiology within each discipline. The other important part of this, and one of the activities that you'll be engaging in during the intercession, is reflective learning and practice. So thinking about what you've learned and how you manage patients. And this is really probably one of the most important skills that you will learn during your 4 years. And I can tell you that it is something that we all do on a daily basis. After you've seen patients in the office, been in the OR, thinking about, okay, what went well? What could I have done better? Whether it's how you communicated with the patient, whether it's a diagnosis that you made, whether it's a treatment that you chose. And so this mindset is critical to have. And it's not something that we're all born with. You know, there are very few people who are born saying, you know, thinking every day, okay, so what went well, what didn't go well, what can I do better, what should I have done, that kind of thing. And that's what we want to encourage. And so reflective practice is about thinking about how you interfaced with your patients, how you interfaced with your colleagues, but then how you approached patients. What could have been done differently? Was it, you know, did you choose the right management plan? Is there a better plan? Did you think about one way to manage your patient, and maybe there's another way out there that you want to think about? So it's how you get feedback, ask for feedback, and improve what you do. You know, improving how we practice medicine. So this is a kind of a big picture view of what the third year is going to look like. So the disciplines are the same, but how they're connected when you take them is going to be a little different. And we have many permutations and combinations of these, up to 24 different choices for when you take each discipline and how you do it. But they will always be, family medicine psych will be paired, OBPs will be paired, internal medicine and neurology, and then surgery and the elective. Okay. So that's kind of a big picture overview. A couple of other questions that we've been asked. So with this change in your third year, is this going to have any adverse impact on the current third years? And the answer is no. So there's going to be no overlap in terms of, you know, having twice the number of students in the clinical learning environment at any given time. The third year is still 52 weeks, so 50 weeks of actual, you know, being in the clinical learning environment, and then 2 weeks for the winter break. We have very specifically made sure that there's never going to be a time when there is an overlap period. We're going to obviously continue this paradigm down the line with future classes. And probably most importantly, we feel that by using this structure, and there are going to be many more details on what this looks like, but that we really think that this is going to help you as you think about taking care of patients, as you prepare actually for any kind of standardized exam that you're going to take. Because I can tell you, whether it's step 2, step 3, whether it's your board exam for your specialty, one of the things that they all have in common is how do you think from a big picture perspective? You know, or if you're choosing a management step, well, why is that the best? Right? There might be 5 different options, but how do you think about the best? You know, what do you have to think about when you make those choices? And so we want to make sure that we are teaching you the strategies and the skills to do that now. All right. I've got, let me see, one more. And the other important part of this is the longitudinal content that we were talking about, so that we are working with our clerkship directors and faculty to make sure that there's specific content that you need to learn about and that needs to be very intentionally brought into the third year, like radiology, healthcare equity, ethics, and a couple of other longitudinal themes that we want to make sure are extended into the third year throughout the different disciplines. And a lot of this we're already doing, but I think what's different and what we're trying to do now is really make sure that we are very explicit about how we're approaching this, so that all of you have these experiences. We don't want any randomness in the clinical curriculum. We want to make sure that everybody is learning the basic content and the basic approach to how you think about patient care. So that is the big picture overview. What questions do you guys have? I see a hand way in the back.
Just to clarify, I think you kind of said it because you mentioned there are many permutations to the clerkship rotations. Yes. So it seems like the order does not matter as long as you're adhering to the pairings. Is that correct?
So I heard if the order does not matter.
Yeah. So like for the, I think you put it was like social. Like so for the pairing process, you said that there are certain clerkships that you go to that are taken back to back. Like that cannot change. But can the order of them change? So can you do psych first and then family? Or
Yep. Yeah, that's a great question. So what your classmate asked is with this, oh, hang on. Oh, uh-oh. Your classmate asked that with these rotations, the clerkships that are paired, can you take one, can they be in a different order? And the answer is yes. Let me just get back to this. Oh, hang on. Get rid of this. Bring this over here. So yeah, you might do family medicine first and then psych, or you might do psych and then family medicine. Or you might do OB first, then peds, or peds, then OB. And we have 24 different permutations and combinations of this that you'll see. Is that is that answer the question? Perfect. Yes?
So you mentioned in the assessment and plan, or in that portion, that that you were doing away with the numerical system. I believe that, is that the 1 through 5 thing?
Correct.
So then what, is there like a substitute you have in mind for that?
So that's a great, so the question is, we are really reframing how we do our clinical competency evaluation. And I think one of the frustrations that many students have had is that, it's a 1 to 5 system, it's a Likert scale, and it can be so subjective. So what your colleague asked is, so what are we going to do? So we have 4 levels of performance that you will be assessed upon. So everything from, there's going to be novice, beginner, competent, which is where we would expect you to be, and then exceeds expectations. There are going to be 4 different kind of categories, if you will. And then and there will be about a dozen different competencies that you're going to be evaluated in. And so one of the considerations for whether or not you have honors or pass will be the percent of time that you are marked at meets expectations or exceeds expectations, or novice and beginner. That in combination with the performance on the subject exam, and then there's another component to your grade that's based on departmental activities, it will truly be a composite of your performance. And it's not, I think, being very frank, I think what students have really had an issue with is that, you can't, the clinical competency evaluations can be very, can have a lot of variability. And so that all of the focus, therefore, has been on, well, then the only thing I can control is the subject exam. And so there's a lot of focus on how you perform on that exam. And our goal is to make this process, to change the approach to assessment so that it's not just about how you do on the subject exam, but really what your composite abilities are. And that's why we're making these changes. So, and I will tell you guys, this is going to be a work in progress. I am sure there are going to be glitches that come up and things that we didn't think about. And so part of the reason for having these conversations now is, one, I want you to ask questions, because you might think of things that we have not thought about. And the other thing is to be very transparent in what we're doing and why we're doing it. And to state at the outset, it's not going to be perfect. It's not going to be perfect. But we are doing everything that we can to really improve and to revise how we're approaching clinical education in a way where you will not only learn and be outstanding physicians, but you will feel that you were also fairly assessed, and that what is conveyed to residency programs truly is an accurate picture of what your skills and abilities are. I think I saw a hand.
I have 2 questions. So the first one is, are evaluators going to be trained in how to appropriately evaluate us within the system?
So that's a great question. If I'm understanding correctly, the question is, are faculty and residents going to be told what we're doing? So yes, we, as part of this process, and that is such a critical question. I'm really glad you asked that. So part of this process, when we look at our steering committee, we are actually divided into 5 different work groups. So one of the work groups is looking at content and structure, one is looking at assessment, one is looking at just that question, faculty engagement and development. So yes, that is, and that includes residents, so absolutely. And that's why, I think, is everybody going to be on board and ready to go? No, there's going to be a learning curve here, but we are going to do everything possible to make sure that everybody knows, absolutely. Was there another part to your question?
My second question is, are other universities moving in this direction as well? And how will this affect how we're seen by residents program since we're already past fail step?
Yeah, that's a great question. So are we doing anything novel and unique? It sounds as what you're asking that's totally, out of the realm of what everybody else is doing. And the answer is no. We are actually, when you look at the number of medical schools that have undergone curriculum reform within the last 5 years, it's probably about 80%. So we are getting to where we need to be. So there is nothing that we're doing that folks are going to think, oh, wow. I mean, I wish, I wish we were really, really being novel and unique. But what we're trying to do, the concept, the idea of being very intentional about integration is certainly nothing new. I mean, this has been around really for probably about 60 years. I think what's different and what makes each medical school unique is how they structure their curriculum to support really how everybody learns, how adults learn. So that's where everybody's a little different. But in terms of what we're doing, no, it's not going to be looked upon like, oh, wow, you're doing that. Yeah.
Has there been any thought into changing the AHEC portion of the curriculum? And I know there were some issues with transportation and commute time and stuff. So.
No, thank you for asking that. The question is about AHEC, and if I'm understanding, one, is anything going to change with AHEC, and then thinking about the transportation challenges with AHEC. So AHEC is always going to be a critical part of our curriculum. The interesting question is what role and how will students be involved with AHEC in the future? Nothing's changing for next year, so there will still be the requirement of 8 weeks. Now, the question that you ask about transportation is one that we have thought a lot about. Right now, I think if it's within an hour commute of Toledo, then you can usually you commute back and forth. There's a gas card that's available for some of the more distant AHECs. One of the things that we had thought about for students who don't have transportation is there some other approach or way to have temporary access to a car? And there's some cities, and I actually don't know if we do it here, where you can pick up a car for a month. And I don't mean going to Avis or Hearst. Do you know what I'm saying? But there are some cities that have this, and so that's one of the things that we've tossed around because we know transportation is a significant issue. But there are definitely gas cards that are available when the commute is more than an hour. And this is actually something that we are still trying to figure out because AHEC is such a critical part of our curriculum, and we expect everybody has to go to an AHEC. Now, there are some AHECs that are in Toledo that are local, but the ones that are far out, if we're saying that we want you to have this experience, because it is a really important experience, is there anything that we need to do differently in terms of how we subsidize that? And I will tell you, those are still conversations that are happening. And it's a great question.
Yeah, I have a roommate, and she's in Findlay, so the commute time ended up being almost an hour, and they still had to do the stipend, and I know it was a little frustrating. So.
Yep, Findlay is a perfect example. I think Findlay is 58 minutes, if you will, and everything is calculated based on their distance from this campus. And so, I think this really is one of the things that we're looking at. It's we don't want it to come down to the number of seconds, the distance between 1 hour and 1 hour and 5 seconds. And one of the things that we've also done is reached out to some of the surrounding universities in Ohio to understand how they deal with remote sites. And what's interesting is that we are probably unique in the sense that we have a significant part of our clinical curriculum involves commuting to sites that are more than an hour away. So we are open, and I am open to any thoughts or suggestions on how we can approach this for next year, because it is important, and I don't think we have the perfect solution yet. Yeah.
So if I understood you correctly before, you're saying that the evaluations will be more on a 4-level system. So who will be creating kind of those 4 levels? Will that be something that the residents and people who are evaluating us are determining what is expected or exceeds expectations, or is there some sort of standard that our clinical team will make up?
So that's a great question, and I just want to make sure I understood it correctly. So the question that was asked is, we said that there are going to be 4 different descriptive levels for your performance. And who is going, how are we going to communicate those, or is it just we're just going to say, look, you're either novice, advanced beginner, competent, or superstar, and who decides that? So, no, it's not just up to the preceptors and to the residents. We actually, we have a subcommittee that's being chaired by Dr. Lori DeShetler, who is our assistant dean for assessment and evaluation, and she and her colleagues have actually taken a very deep dive into what does it mean. So what does it mean to be competent or meets expectations? And relative to what? So we're thinking about, is this going to be at the end of third year, at the end of fourth year? We're saying, and we're going to be able to say to you by May 2nd of next year, this is what we expect of you for every single clerkship. This is how we would say you are competent. In other words, you're where you should be. Now, we know that there are going to be some students, obviously, who exceed that in certain competencies. That's great. And that's going to be the difference then in whether you're honors or whether you have a passing grade. So no, and I really want to, and I'm so glad you asked this question. So no, this is not going to be just at the whim of the preceptor who's evaluating you. We are really trying to make these anchors descriptive so that, if I check the box that you are competent in a certain skill in OBGYN, that somebody else watching you do that same skill would check the exact same box. So we're trying to eliminate that subjectivity and just kind of saying, yeah, well, she's nice, she's competent. So we're eliminating that. That's one of the main goals of our reform in terms of the assessment.
And then just to follow up, is there a way that we're going to ensure, or I guess communicate to everybody that I think there is a fear that if you're the type of person that asks a lot of questions or maybe doesn't understand something at the beginning of a rotation, that could be ill-reflected when it comes to that sort of competency grading. So how do we make sure that students feel comfortable to still ask questions without fear of your preceptor saying, oh, well, then you're just not competent in that skill?
So if I'm understanding you correctly, what you're asking is that if you're a student on a team and you have questions, should you be penalized, or will you be penalized for asking questions? So I'm going to say that I hope the answer is no. And I don't know, Dr. Mattis, if you have any thoughts on this in the world of family medicine, but we always, honestly, the discourse is what's so important, and we try to encourage that in the classroom, in the foundational sciences, and honestly, that to me is a critical part of learning, not just for you, but for everybody on your team. And I know one of the things that a lot of us say is, probably the question you're asking is a question that 5 other people would like to ask, but don't want to be the ones asking. So you bring up, and I think part of this is faculty development. We want to make sure that our preceptors, residents, faculty are evaluating you, understand that asking questions is a good thing. That is part of being that is part of the lifelong learning and self-directed skills that you need to know when to ask when something doesn't make sense. So, and I don't know, Dr. Mattis, if you have any thoughts on that?
Yeah, I completely agree. I know sometimes it can be intimidating, but especially during your third year, I always tell students, that's the time, it's your opportunity to ask anything.
Right.
And I mean, I'm not talking about like, what's the dose of Lasix? I mean, you can look that up in Hippocrates, but when you ask questions, it shows that you're thinking. And I think especially third year, you start to feel like you're just supposed to come with information and know everything. But I would much rather hear an insightful question that shows me what you're thinking and can help me help you get to the next level. And so I would way rather have students ask questions and again show that they're more than a reporter, that they're integrating, that they're thinking, synthesizing information. So I can't guarantee that's every rotation, but I think in general, faculty want to hear students' thought process.
Yep. And that's the key. It's your thought process. In one of the things that we try to emphasize, it's not whether you get the answer right or wrong, because honestly, at the end of the day, that's great if you did, but how did you arrive at that answer? What was your thought process? So sometimes the questions that you may be asked are, can you tell us how you came up with that diagnosis. And the question, I think the question that you're really asking is, do we have an environment, a learning environment and a culture that supports curiosity and a spirit of inquiry? And my answer to you would be, I really hope so, but can we guarantee that every single person that you interface with is going to have the skill set to foster that? Probably not. Do we need to work on that? Absolutely. Absolutely. So it's a good question. Appreciate it. Okay, I saw a hand back there.
So I think this question is kind of a follow-up to the previous question. It's a little bit complicated, so my apologies if I ran a little bit. It's basically, depending on who mentors you, who you work under, experiences may vary, right? I think some of the goals for having a new standard or having new competencies is to standardize evaluation and make things fair, regardless of who you get. So I'm in M1, and I don't really know much about what happens later on, but is there going to be a little bit more standardization or involvement from the school in guiding self-study learning and checking into the experience? Because I think one thing that may happen or does happen is you may have a great mentor, or you may not have a great mentor, and there's still stuff you got to do at home. And how do these goals of integrating basic science and clinical skills, how does that affect your day-to-day and how you should be focusing your time? Is everything going to be learned at the clinical site, or is it really is there going to be more involvement from the school directly to the student as well? Is that kind of?
I think I understand what you're asking. So and tell me if this is a correct paraphrasing of what you said. That we're very much focusing on how you connect your knowledge, whether it's connecting your knowledge from foundational sciences back into clinical care, whether we're talking about knowledge and content across disciplines. That all sounds great, but how is it? In other words, how are we actually going to operationalize that? So that is exactly what we are doing and what we are working on right now for the steering committee in our work groups. Just that question, because you're right. We can't just say, hey, when you're on neurology, make sure you understand the anatomy of the brain. That's not going to help you very much. But what we are going to do is we're going to make sure that there are very explicit learning objectives, very similar to what you guys are doing now, whether you're an M1 or an M2. Learning objectives are set out, and that you guide your learning toward those objectives. And that doesn't change in the third and fourth year. Every single clerkship, every single clinical elective has a set of objectives, what you need to learn. Now, you ask an interesting question, though. So, is there any oversight to this process, and is there any standardization? And so I want to answer that with an absolute definitive yes, yes, and yes. And so part of the oversight, if you will, of our clinical curriculum is in the hands of our clinical curriculum committee. And these are just the things we meet on a monthly basis. And this is exactly the type of thing that we talk about, is we make sure that even though you're at a different site for a specific discipline, that you are still getting an equivalent experience. And an equivalent experience means that the learning objectives, those objectives that are stated for your clerkships, let's say you're doing internal medicine, it shouldn't matter whether you are at UTMC, Toledo Hospital, or an AHEC site, you will still meet those learning objectives. The context may be different, obviously, but the objectives will be the same. So the oversight doesn't change. We're not just saying, okay, everybody integrate, let's break. It's really, there's a lot of thought that's going into this, and the oversight doesn't stop. The other question that you asked was, so in terms of your learning, is it all going to be done, while you're seeing patients, whether you're in the inpatient, outpatient setting? And I can tell you that the answer to your question is no. As a matter of fact, that's never the case. So you learn a lot, when you take care of patients, but a lot of what you learn is after you leave the office. There's not a day that goes by when I'm not working, seeing patients, inpatient or outpatient setting, where I don't, at the end of the day, after I'm done in the office, then I have, go home and have to look a lot of things up. So the learning, the patients are going to be the rich material that are your springboard, for what you want to think about in terms of each discipline. But the learning, that time where you think about, all right, so the anatomy, the physiology, the management, that happens most of the time after you leave. And then that's just, that's for the rest of your life. That was a good, I appreciate the question. It's a great question. Did that answer everything?
Yeah, pretty much.
Okay. Who else? Yeah.
I still have a couple questions here. One, is signing up still going to be done the same?
Oh, is Dr. Worth still here?
Just left.
Oh, too bad. So, so I think you're talking about track registration.
Isn't it like it opens up and it's like a mad rush?
So that is, for med ed, we obviously, the curriculum is our purview. How that track registration is run is actually overseen by student affairs. So I can tell you how many tracks there'll be, and I can show them all to you ahead of time. What I can't tell you is what that process is going to be like this year. And I don't know if you guys have heard either Dr. Mattis or Dr. Lauka, but
I think student affairs is fully aware
Yeah.
of the stresses that occur that day, that evening, what have you, and I think they're looking at other creative ways to make it a little bit better, more manageable. I know that there are programs that do a lottery system, and there's lots of different things that are available, but I think Dr. Worth, that would be a good,
Yep.
all kingdom.
And his timing was perfect. But it's and we know that, as Dr. Lauka said, this has been a source of angst.
Just the other two really quick. So this isn't going to affect like any of the locations that we're doing this at? Like, those are still available and everything? Right?
Oh yeah, no, locations, everything's going to be the same there. Yep.
Okay, and
Yep.
then, is there a big overhaul of fourth year as well, or is this just third year?
So we've already made a lot of changes in fourth year with the addition of a transition to residency thread. However, there is more that we need to do. The focus between now and May of next year is the third year. But this reform process, is actually going to continue going on until 2025. So there's many, many phases to this. But the things that we really wanted to focus on and have ready to go by the time you guys start, it's the structure of the third year and the assessment piece. But we want to make everything better. Nothing's ever perfect. We can always make it better. What else, you guys? Oh, yeah.
Will there be any sort of change in the focus or scope of the shelf exams?
Will there be any change in the focus? You mean in terms of how much what it counts for toward?
Longitudinal information and sort of different integration?
Are you asking in terms of integration, how we're going to assess that, or do you mean how the shelf exams count?
I guess both. Or like with the shelf exams, would it be like a biopsychosocial shelf, or would you still have a separate family management?
Yeah. So no, that's a really important question. So the subject exams are still going to count for 30% of your grade. That's not going to change. Now, the interesting question is how we assess the integration, and that's where we are having the discussion right now, whether it would be a separate kind of a separate exam that would include overlap material, or whether it would be more of an OSCE type of exam, or similar to what you're doing with the ICSE, where you come in, see a patient, and then you're evaluated for how you get the history, physical, and things like that. So that's the part that we are working on right now, and it'll definitely be a pass-fail kind of thing. It's not. Best we know, there's not going to be a specific number of points, but it's going to be really important that you demonstrate the skills to kind of connect your knowledge across disciplines. Did that answer? Yeah. That's a good question. What else? Oh, I see a hand back there.
Yes. So right now we have like wellness days built into our schedule, which is wonderful because it shows that the faculty's considering our wellness. And I'm wondering, will there be consideration of that kind of thing and how to, maintain our mental health?
Yes.
Third and fourth year, which is kind of like thrown to the wolves.
No, that's a great question. So one of the subgroups that we have, one of our working groups for this reform, is just about that. It's about student well-being, wellness, professional identity, and Dr. Mattis is heading that up. Do you want to make any comments, or other than yes, we are definitely?
And there are students on the committee as well
Yeah.
that from really several different levels that are getting input as well, so definitely something to keep in mind.
And that's part of what these integration intersessions. A component of it is also going to be about wellness. And wellness is a longitudinal thread. It's not something where we say, okay, here's an hour, but it's really how do we foster that across all 4 years. And so clearly there's a lot that's gone on in the first 18 months, and we want to make sure that we extend that into the 3rd and 4th year. Absolutely. What else? Yep.
Can you talk about how feedback works? Like once you're in the first family medicine rotation and you have some thoughts, concerns, is anything changing with that, the way you do it?
So do you mean feedback if you have a concern?
Yeah.
Yeah.
So
No.
that's partially why I asked about who's responsible for your learning.
Ah.
We are always responsible for our
Yeah,
learning,
yeah.
but with so many things, where are we supposed to look to? And so part of what I think is, if we have a set of learning objectives, what can I expect to be taught in the clinic, and what can I expect to teach myself at home or bring, in preparation for the clinic, and what happens when you notice that there's a discrepancy there?
So I think there are a couple of parts to answer your question. So one, in terms of ensuring, so the question is, if I'm asking, if I'm understanding correctly, part of it is what kind of communication is had with you as students that you are where you need to be during a clerkship, right? Because we know that there are learning objectives, what you need to learn, but how do you know you're actually meeting that objective? And we don't want to wait till the end to tell you that. So in every single clerkship, you get mid-clerkship feedback. And this is across the board in all of our required clerkships, in the middle of the clerkship, from the clerkship directors, kind of checking in with you. How are things going? Do you feel, is your learning experience what we said it would be? Anything, what's working, what's not? Clerkship directors also go through your case logs with you, so that's a significant component of the 3rd year. There are required clinical experiences for every single clerkship. And so one of the things that the clerkship director does at that mid-clerkship meeting is to make sure that you're on target to complete all those experiences. So our clerkship directors do a really good job of making sure that you are where you need to be. And if you're not, that conversation is had sooner rather than later. Now, are you also asking the opposite if you have concerns about an incident or something? So yes, so that, and I think that is also an extremely important question. So the same mechanism that you have to report any concerns in the learning environment, you guys know that learning environment. So that's still, that is still an option in the 3rd year. It doesn't change. And actually, I just want to emphasize that is so important, that if you have concerns, that you let us know. And if you want to do it anonymously, there's that learning environment link. If there's an issue and you feel comfortable talking to your clerkship director, talk to your clerkship director. If you need to talk to me, Dr. Mattis, Dr. Lauka. If there are concerns, and I really want to make sure that you guys hear this, we want to know. Because, things are challenging enough. There's enough to just learning everything that you need to learn. But what we don't want to have is we don't want there to be any other issues, because that is not okay. We have zero tolerance, actually, for any kind of unprofessional behaviors. And if you feel that is happening, we want to know. So that badge, I think you guys all have your badge buddies, right? They still work in the 3rd and 4th year, and we really encourage you to use those.
So just the only follow-up to that is there any, there was this one lecture we had recently, maybe 3 weeks ago, on moral distress, and some ethics stuff. Is there anything like that will be presented before we start rotations, or a rotation in particular?
That is a great question. Dr. Mattis?
So our committee is well
Thank you. Yeah.
Kind of follow up to that, will there be any training for the faculty on like anti-bias? So we're talking about like if a patient does something, staff member, but like for our faculty, how can we control that? But then also AHEC or any of the other clinical sites, how do we control that for that?
So the question is, do our faculty, do they either get training about on implicit bias, or is that planned? And so we all, anyone who's in the clinical learning environment does have annual training that they have to do that involves bias. But we also know that there are other opportunities to talk about this, and so the question that you've just asked is something that we are taking a look into. We have a health equity subgroup that is looking at just this question, because equity is such a critical principle in our curriculum. It's important, in everything that we do. And yet, if we don't have all of our preceptors on board with that, then the curriculum's not going to work, and the care that we give is not going to work. So the answer to your question is yes, and we're trying to figure out how to expand what we do. And I can tell you that it's probably going to be at least a 2-year process. Our thought is to start with new, like faculty who are onboarded, and then have a plan from there. But yes, that is absolutely being thought about. Yeah.
I'm not sure if this is a question for you and my curriculum or more for you guys, but when will we learn about third year? Like what it is, whether it's how we decide what schedule is best for us and our preferences, or what even happens during those 8.5 weeks of internal med?
So the question that was asked is, when do you actually get to learn about third year? And so part of the reason that we all wanted to start meeting with you today is to have this discussion, because we don't want you guys to be blindsided. So that's part of it. In terms of tracks and things like that, that is something that is organized by Student Affairs, and I think fall, usually.
Yeah, you're referring to third-year orientation.
Yeah.
And that typically happens in October.
Yeah, like early fall. Early fall.
It's a little earlier.
Yeah.
I believe last year maybe it was October.
Yeah.
So you should be getting something soon if you haven't already.
Because it's a lot. It seems, it is a lot,
That's when you talk about the different tracks,
Yeah.
the process, and
But that said, one of the things that I wanted to propose to you guys as a class is, that we would love to come and have these updates with you to kind of keep, because I think the communication is really important, and so, be willing to do this on, every 2 weeks or every month, whatever you think would be helpful, because the formal third-year orientation will occur, and it's how the process, like what do you look for, how do you register for tracks, but there's so much more to it, and so we want to make sure that you have an opportunity to ask all the questions that you need to have answers to.
A similar question, I'll be honest, it's not really about third year, but while I have you guys all in the same room, when did we learn about STEP?
Learn about
STEP. Like step 1.
Oh, STEP. That's a great question.
So interesting enough, you learn about STEP and your third year during the same session.
Yeah.
So Dr. Mattis, gives a presentation, and then Dr. Wirth does his thing for Student Affairs. I just actually pinged for Dr. Wirth to see if he has a date in mind already.
And you meant step 1, not step 2.
Yes, yeah.
Oh, okay. All right. Okay.
Step 1 is still important.
Yeah. Oh, yeah. No, thank you.